Good Monday morning, everyone. I am so happy to be back with you guys today. And we have our friends from Facebook and Instagram joining us as well. So super exciting to get started. Let's go ahead and make sure that we are live on everything. All right, there we go. So I am so excited for you guys to join us on Zoom, Restream, and Instagram today, also YouTube, Facebook. So this brings me to my first poll question today, and that is, where are you guys joining from? So I'm going to go ahead and put up a poll for you, and you guys let me know where you're joining from. And also, I want to know a little bit about your background and training experience. So if you haven't joined us at Slido, I'm going to put up the QR code for y'all here. And I hope y'all can see this. Let's see here, because this is my first time going live on all four platforms. So if you can see it, just let me know. If you can't, let me know. And I'm going to give y'all the Slido here. I'm going to come back to that in just a minute. So here is how you can join on Slido. Slido.com, hashtag guidelines. So go there, check it out, see what you can see, um, see if you can get on there and do Slido. Okay. All right. So let's see here. Also, if we haven't met, my name is Brittany. I'm a nurse practitioner here at Archer Review, and today we're going to be going over screening guidelines, like I mentioned already. And, this is one thing that can be kind of a challenge for nurse practitioners, and just trying to get our heads around all the guidelines and where to find them. We want to make sure that we're utilizing evidence-based information. So this is one that's kind of near and dear to my heart. So something that I definitely want you to be paying attention to. All righty. So let's see here. All right. So I'll give you just a minute to join at slido.com. And there we go. All right. Okay. So join at slido.com and hashtag guidelines. Okay. So again, welcome. I see people are still kind of getting on today. It's Monday morning, right? So I try not to do these things too bright and early for you guys because I know it's Monday morning. So, all right. So go ahead. I'm going to put up the guidelines for y'all. Tell me what your background, training, and experience is. Where are you joining from? Let me know. I always like to know who I'm talking to out there. I don't want to just talk to myself. Okay, so you've just finished nurse practitioner school in Connecticut. It might be still cold up there. We're starting to have a little bit of spring in Alabama, and I don't have a voice, but we do have flowers in the yard. So, which one do you want, right? Okay. I'll give y'all just a minute. Okay, F&P. All right. All right. Where else are y'all joining from? Tell me a little bit about your background, training, and experience. I know several of you all are either in NP school, just finished NP school, or maybe you have a little bit of experience under your belt, but regardless, we're super excited to have you join us. And I have some super exciting news for us today. And in the past, just really week or two, we have been granted accreditation from ANCC to do contact hours for you guys. And I'm going to go ahead and pull that up for y'all on the screen there so that I can give y'all my little disclaimer here before we go any further. And y'all can still keep putting in where you're from. I'm going to come back to this in just a minute. Okay. All right. Connecticut, can the person call me and we can study together? Hey, there you go. Connecticut study group happening right now live today. So if you're in Connecticut, you might want to get started there, huh? Okay, so I've got the screening guidelines here for you. Join at Slido. And then let's just back up just a little bit, just disclosures. We are now accredited as a provider of continuing professional development by the American Nurses Credentialing Center Commission on Accreditation. So, super exciting news. The team here went into a lot of hard work, and this course will be accredited for one contact hour. But the only caveat to that is that you have to be joining via Zoom. So, if you haven't joined via Zoom, then you'll get them next time. It's okay. But you can go to our website, archerreview.com. You can sign up. And as long as you are here via Zoom, you will get that. That way we have your email and can send you your certificate. Also, there's no relevant financial relationships. With that we need to disclose for this particular webinar today, or commercial interest as well. So again, just a strictly educational free activity for you. Hopefully it is beneficial. The other thing is learning objectives. So we always want to talk about what do we want you to know at the end of our time together. Of course, today we're talking about guidelines and screenings, right? So I want you to identify common screening guidelines with AB recommendations. I want you to explain the rationale behind the AB guidelines per the United States Preventative Task Force. And I did put that link in there for you in the chats on Zoom. It's just United States Preventative Task Force.com. And I want you to demonstrate an understanding of how to locate and discuss these evidence-based protocols with your patients. So again, really important for us as we're going and we're talking in these patient rooms, that we are breaking down the information for them, that we're disseminating the information in an understandable way to the public so that we can help them. Of course, nurse practitioners, health promotion and prevention is a huge part of our job role. So again, just something to be mindful of there as you're going through. Again, this is your learning objectives if you're taking this for continuing education. All right, again, if you are just now joining us, I want you to join us at slido.com, #guidelines. I want you to get in a little fun. It's no fun if I'm just talking to myself all morning. So I want you guys to interact. And I'm going to go back here and see here. So experience, okay, from Saudi Arabia, welcome. I am super, super excited to have all of you guys here, regardless of what platform you are watching on. We're going to have a good day today. I have lots and lots of questions for you guys, and just some really fun stuff as we go along in the webinar. All right, so here in Alabama, we just had spring break. I don't know where you're at, but you're probably going to have spring break coming up in the next few days. But I want to know where your dream spring break trip has been. Where are you going to go? Where do you want to go? Where did you go last year? Where do you hope to go next year? This is just kind of giving y'all time to practice before we get into the actual content here. It just gives you some time to practice utilizing Slido if you're not familiar with that. Ooh, I'm so jealous. Mexico and the Cayman Islands. Ooh, I hope you actually went. But I got to see my parents for a few days last week, so it was really good. So it's always fun to get together with family, but it's super fun to get to go away to somewhere warm and sunny for sure. So give y'all just a minute to respond here, just to practice utilizing Slido anywhere that's far away and tropical. Absolutely, that is definitely your best spring break trip for sure, or those sunny, warm locations after a long winter for sure. So, anyway, so glad. Oh, Southeast Asia, that's going to be really fun. We just had a coworker that went to Thailand, and I think it was a really good experience for her from what she described. San Diego, always warm and sunny there. That's also on my bucket list. So I would like to go to San Diego. I've heard there's a really great like zoo and stuff there. So want to take the kiddos there. So, okay. All right. Ghana. Okay. Awesome. Okay. So you guys are really just world travelers here. It sounds like I need to get out a little bit more. All right, so let's go ahead and get started on our screening guidelines today, and take a look here at what we want to do. I'm going to pop y'all back to our screen here, and let's go ahead and get into our content so that we can get y'all out on time. So you guys, I want to know, where do you all find guidelines at? Okay, first of all, how confident do you feel knowing where to find the guidelines? So from not confident at all to pretty confident here, with a smiley face, heart eyes. Where are y'all finding good? So some of y'all feel like, yeah, not too sure. And it's daunting out there. There is, I remember asking a professor one time, hey, where's like the website where we can just like have everything compiled? And they're like, there's not really one. So it's newsflash there. This is just kind of a piecemeal. You can get your information. There's a lot of great places to find specific guidelines, but there's nowhere that's just like a huge bank that I know of to get them all together. So let's go through, and then also I want to know where you all are finding your quality evidence-based information discussed with your patients. So again, I've just listed the United States Preventative Task Force. We're going to be talking through that one today specifically. But there's lots and lots of places to get guidelines. We've talked about GINA before in the past. We've talked about American Diabetes Association. We've talked about that global initiative for asthma, that GINA, like I said. We've talked about GOLD for COPD. We've talked about, lots of different guidelines here at Archer. And again, I'm focusing on United States Preventative Task Force today for these screening guidelines. But, we want to always make sure that we're finding quality, evidence-based information. We're in and out of exam rooms all day. We're that first line. MedQuest absolutely gives them up to date, has them. Sometimes you'll find them on Hippocrates, depending on what you're doing. ISDA, infectious disease guidelines. So lots of different places to get them. And lots of places for you to be looking and kind of researching. So again, let's go ahead and take a look here at the United States Preventative Task Force and what they're essentially saying to us. So you guys have started some great places to work with at first. But when we find guidelines, of course, we want to make sure that they're evidence-based before recommending them to our patients. And I put a link in the chat for you if you're on Zoom. Again, it's just UnitedStatesPreventativeTaskForce.com. And basically, I'm going to refer to that as USPSTF going forward. Just it's a mouthful. But this is just what the task force mission is. They state on their website, the task force works to improve the health of people nationwide by making evidence-based recommendations on effective ways to prevent disease and prolong life. So again, thinking about your cancer screenings, things like that. And then they continue on through this work. The task force helps healthcare providers and their patients work together to make informed decisions about preventative care. So again, go ahead and feel free to save this link. You're going to be referred to this often if you're in primary care because there's over 80 different health conditions and diseases across the lifespan that the USPSTF makes a recommended screening guideline for. Also, counseling. We are, again, health promotion and health, and prevention strategists. So we want to counsel these patients on everything from smoking cessation to obesity. So again, this is going to be a handy resource to keep on your desk. And many of these screenings, I want you guys to be aware of this too. These counseling and screening recommendations also apply to people without any actual evidence of a specific disease or condition, which actually brings me to my next topic. Now, I don't want you to stress when you see this alphabet soup here, okay? Let's talk about this. Let's break this down just a little bit, okay? Now, every screening recommendation is going to be assigned a letter, either A, B, C, D, or I. And we are going to be focusing on the AB recommendations. Now, why would I only focus on the AB? Time, obviously. But the reason is because these are the ones that are actually recommended. In order to recommend a guideline, I need to know that the net benefit to my patient is going to be a moderate, at least moderate, maybe even a higher likelihood that the patient's net benefit is going to be substantial. So, for example, A and B, something like screening for syphilis in pregnancy, that's one of those guidelines. It's going to have a benefit to the patient, right? We're going to recommend that screening. Whereas category C is going to have a net benefit small. So maybe it's going to be one of those that it's not going to account for every single patient in your practice, but if we're doing individualized care plans, we might utilize a C recommended guideline. However, D is discouraged. There's going to be little evidence to support a D. And then I is insufficient, as in there's very little evidence. We're not real sure if it's going to actually be beneficial or even harmful for the patient. And so we're not going to usually recommend these. So again, A and B is going to be for the general public. That's the ones we're going to focus on today. C, the net benefit is small, but again, small populations, you might consider it on an individualized care plan. D and I, we're not really doing for anyone. All right, so now let's talk a little bit more about prevention. Okay, so again, I just mentioned to you guys that one of the key critical roles of being a nurse practitioner is helping our patients to know their prevention strategies and their health promotion. So remember when I stated that these guidelines pertain to someone even if they're absent of a disease or illness. So remember, screenings are a type of prevention. And I was just wondering if you guys remember the three types of prevention. I'm going to go ahead and review them very quickly here with you. And then what we're going to do is I'll give you all a couple practice questions to make sure that you know how to apply the information. So the first one is going to be your primary prevention, okay? This is essentially existing to educate a patient. These patients don't have any indication of disease, and we want to think about educational topics that we want to really strategize and work on a primary prevention with our patient. So think about the entire lifespan. So when we vaccinate an infant, when we tell a young child to wear their bicycle helmet, when we remind an adolescent to wear their seatbelt when they're starting to drive, or maybe we're educating an adult on a safe sex practice, or maybe we have a geriatric patient that we're discussing strategies to prevent a fall. These are all examples of primary prevention because I want you to think about P, primary, P, prevent. So we're trying to prevent anything from happening, prevent an episode before it occurs. Okay. And then I want you to think about secondary prevention, and that's what the heart and soul of this topic is today, is these screenings, okay? So when I say secondary, I want you to remember the S in screening, okay? And this is where our USPSTF guidelines are going to come into play. And for example, if I recommend a screening mammogram, colonoscopy, or pap smear, these are all A and B guidelines that should be followed. And then remember, when I'm utilizing primary or secondary prevention strategies, there's usually not any sign or symptom of disease or condition. And so if you are on a boards test or on some sort of test and you encounter a question that discusses any event that the patient has had and you're trying to bring them back to baseline, you automatically know that it's not going to be primary or secondary, but rather it's going to be tertiary. And I want you to remember T for tertiary, T for throwback, because essentially we're trying to help that patient return to baseline after some sort of injury, illness, or disease. So I want you to think about this patient maybe has diabetes and we're talking with them about lowering the A1C. Or maybe a patient has had a stroke and we're giving them some antiplatelet medications. Or maybe we're asking a family member to demonstrate how to administer an epinephrine pen after a bee sting. We are essentially providing tertiary prevention to try to bring that patient back into a homeostasis state, if you will. So let's go ahead and move on and do a practice question. Again, if you have just recently joined us, you can join us at slido.com hashtag guidelines. I've got the QR up for you here if you need to scan it. So let's look at our very first question that I have for you guys today. Andre is a 5-year-old male brought in by his mother for a well child checkup. When asked what he enjoys doing in his free time, his mother states he loves to ride his bike. The nurse practitioner responds with a statement about the importance of wearing a helmet. She then decides to give Andre a coloring workbook on bike safety to take home. Which prevention strategy did the nurse practitioner implement? So, is this primary, secondary, tertiary, or concurrent? So, I'm going to let you all go ahead and think about it. And you all are already on it before I can even get there, aren't you? Absolutely. This is primary prevention. We don't have anywhere in the question that Andres had a bike wreck, that he's been injured on his bike. He just likes to ride his bike. And so we're going to do primary prevention strategies here. Absolutely. That's a great job, guys. All right, let's go ahead and look at this one. So we talked about that primary. Tom, he's age 72, being evaluated by the nurse practitioner and is noted to have weakness of the right lower extremity. His wife states last year Tom suffered a stroke and has had 2 falls in the past 6 months. Tom is utilizing his walker today, but the nurse practitioner orders a physical therapy evaluation and treatment plan. What type of prevention is the nurse practitioner suggesting? So, primary, secondary, or tertiary? I threw in a distractor on that last question. I guess I wasn't feeling as clever on this one, was I? So, what y'all thinking? Prescribing physical therapy for a stroke victim to reduce the risk of falls. So, what are we thinking? So, Tom's already had an event, right? So, we talked about we're going to throw him back. We're going to try to bring him back to his baseline. He wasn't falling before the stroke. Now he's been falling the last 6 months. And we're going to go ahead and do tertiary prevention strategies to try to help bring his strength back up so that he's not having so many falls. So great job. You guys are on it. All right. Okay, let's take a look here. So absolutely, that's tertiary. Y'all got that. All right, so let's just take a little brain break. I have been spouting off information for 20 minutes and the time is just passing so fast, isn't it? So, maybe you are just getting started on your schooling or you're getting ready to start for boards or you have been out for a little while, practicing as a nurse practitioner. And regardless of where you're at in your journey, we want to come alongside you and help you. And one of the things that I just love about working here at Archer is that, again, our mission, vision, and values here talks about affordable and effective resources to help you conquer your exam. But then we also offer mentoring as well. And one of the things we have is this question bank. We're wanting you to do questions every week if you're getting ready to set for your boards exams. Maybe you're in school. We have on demand, which is just bite-sized content where we've literally sat down and talked with you about every topic that you can imagine in a bite-sized, easy to understand, broken down way. So you want to just talk about, asthma today, you just go right there and it will talk to you all about asthma. Or maybe you want to talk about rashes, it takes you right there. And so that's really nice on those sticky spots. And then, of course, we have the SurePass Pro, and that combines these two things together, plus a live review that's going to happen in May, like 2 to 3 days in May. So if you're graduating coming up, consider gifting that to yourself or a friend. We'll have more information about that coming up. And then also some mentoring time as well. We like to sit down with you, work on study plans together, and this has a pass rate guarantee. So again, right here, you can scan to find out more information about SurePass Pro. And then regardless of what you do or buy today, we just want to connect with you. I am so excited to be across all 4 platforms today that we have within Archer Review. And I'm sure more will be coming down the pipeline as social media continues to expand. But we have channels on TikTok, Facebook, Instagram, YouTube, and we want to connect with you. We often will advertise these free CE webinars like we're doing today. We will give you practice questions. I even saw some videos on there the other day showing how to conduct some of the tests for your physical assessments. So lots of really exciting things coming down for you guys here at Archer. And maybe this package or this connection here isn't exactly what you're looking for. We'll be happy happy to talk to you more, and you can email us for questions at nursepractitioner@archerreview.com, because again, we're just trying to kind of come alongside you and connect, and we want to be there for you every step of your journey as wherever you're trying to get to. So always happy to reach out and talk with you one-on-one. And of course, check out our options for you if you feeling a little overwhelmed, because this is a lot. All right, so I'm going to give y'all a Slido question to talk about for our first topic here. Mr. Hassan is 68 years old. He comes in for a new patient exam. Excuse me. He states he's been a smoker for about 40 years and has never had any screenings. The nurse practitioner plans for which of the following? So again, he smoked for 40 years. He hasn't had any screenings. This is the first time you've met him today. What do you want to do? And this is a select all that apply. ANCC does have select all that applies on their boards if you're going to be taking that coming up soon, or if you've taken it before. But select all that apply here. A, order an ultrasound to screen for abdominal aortic aneurysm, order a low-dose CT scan, provide smoking cessation counseling, or offer prescriptions for nicotine patches. So again, you can go there and you can look on the USPSTF guidelines. It will give it to you, but go ahead and think about what you would like to do. And again, remember, this is select all that apply. So think about what needs to be done for this patient. He's 68 years old. Think about the guidelines that you've read. And again, if you missed this question, it's no problem, because we're getting ready to go on and talk about this. So let's just test your knowledge. Let's just see how you're doing, see if you're staying awake. And again, this is a select all that applies. So you all know you need to at least pick two answers, and decide what you would like to do for Mr. Hassan today. This is the first time you've met him. So what are we going to counsel him on? What are we going to offer to him? What are we going to do for him today? What is important to us as health promoters, disease preventers, and good examples for our community? What is important to us to provide for him in our visit today? So think about that as we go on, and we're going to go ahead and get into the screening guidelines specifically for people who smoke and lung cancer. So I'm going to go ahead, and I'll come back to this here just in a minute, but let's go ahead and talk about this here just in a second. I'll give you a minute. All right. So before I give the answer, we'll go over the screening, and then I'll let you all try again. So first of all, let's talk about these lung cancer screenings, okay? So if you guys remember, the number one cancer in the US that leads to death is lung cancer. And it is imperative for us to screen these vulnerable populations, i.e. smokers. And the USPSTF recommends screening all adults aged 50 to 80 years old who have a 20-year lifetime pack history of smoking and currently smoke cigarettes, or have quit smoking within the last 15 years. Now, who can tell me how to calculate a smoker's pack history? I'm going to give you all here just in a second an opportunity to calculate a pack history. So remember, pack history is going to be calculated by multiplying the number of packs per day by the number of years a person has smoked. So for example, if I say that your patient has smoked 2 packs per day over the last 10 years, then I'll multiply 2 times 10 and come up with a 20-year pack history. So let me give you all an example, and we'll talk about it. So the example is going to be, this patient has smoked 2 packs per day times 15 years. So let's practice this, coming up with a pack history. Our patient has smoked 15 years, 2 packs per day. What is their pack year history? So again, we're going to multiply those two numbers together. And what are you all getting? Absolutely. Very good. That's right. We're getting 30. So we know that 15 years times 2 packs per day, or 15 times 2, equals 30. That's right. And this patient that I'm describing to you all would be a candidate for this low-dose CT scan based upon guidelines, right? So great job. Okay. So let's go ahead and talk a little bit more about this, about screening, okay? So, do you all remember what test is used to screen for lung cancer? That's going to be your low dose CT scan, right? And the low dose CT scan will be conducted every year. And of course, this is an expensive and costly test for patients. It's radiation exposure, even though it's a lower radiation dose and they're not necessarily getting IV contrast, it still has a little bit of exposure. And we need to make sure that that patient is going to be agreeable to doing this long term every year and then also undergoing cancer treatments if any areas are found that reveal like a malignancy or something that needs biopsied. They need to be agreeable to get treatment because again we want to be good stewards of our imaging. And in addition to the low dose CT scan, I've got it here in a clinical pearl for you guys. USPSTF recommend men aged 65 to 75 with any smoking history be offered a one-time screen with ultrasound for an abdominal aortic aneurysm. Again, age 65 to 75. So remember that for just a minute. And of course, offering counseling on smoking cessation and a behavioral change therapy or medication is also listed as a grade A guideline. So if we go back to our question over here, I'm going to give you just a second. Mr. Hassan, 68 years old, comes in for new patient exam. He's been a smoker for 40 pack years and has never had any screenings. The nurse practitioner plans for which of the following again select all that apply. Excuse me. So give y'all just a minute to do that. Um, Low dose CT scan, ultrasound to screen for abdominal aortic aneurysm. Remember your clinical pearl, 65 to 75. If he hasn't had that before, he's going to be a candidate for that. Of course, we are working on smoking cessation counseling and prescription nicotine patches. So, very good, you guys. Y'all got that, and I'll go back here and all the things we're going to do for him. All right, let's go ahead and take a look at this one. So this is a practice question about PAPs. The nurse practitioner performed PAP testing on a 35-year-old female, and the results were atypical squamous cells of undetermined significance, or ASCUS. And she's also positive for human papillomavirus, or HPV. What is the appropriate next step? And I'll go ahead and pull up Slido for you guys. We'll read the answers together in here. Let's take a look here. So again, repeat PAP testing in 6 to 12 months. Refer to gynecology for a colposcopy. Repeat the PAP test immediately or repeat it in 3 years per the guideline schedule. So I'll take you just a minute. You all can look at this, test your understanding, and then we'll get into the content, and then we'll come back and look at it again together. So again, 35 years old, ASCUS plus HPV. So, all right, let's go ahead. You guys are on it today. Y'all are doing great. Okay, absolutely. This patient's going for a colposcopy. Now we'll talk about that here just a minute on this next slide. Okay, so y'all got it. Refer to gynecology for a colposcopy. So before we get into PAP testing guidelines or anything like that, just a reminder for you guys, let's talk about PAP testing. What is it and how to collect a cervical cell sample? Remember, a PAP smear is going to be that screening test designed to detect abnormal cells, which may indicate the presence of cervical cancer or precancerous conditions. And during this test, the provider, i.e., the nurse practitioner, collects cells from the cervix, that lower part of the uterus that connects right here, lower part of the uterus that connects to the vaginal canal. And then these cells are going to be looked at under a microscope, usually off-site by a pathologist. So the patient's usually lying down in supine position in stirrups. We, of course, as providers, want to provide that privacy and empathy. And of course, if you insert the speculum kind of at a downward angle, that helps that cervix to kind of pop into view. And then we'll be able to collect those cells from the cervix using both a little spatula and a little cone brush so that we don't miss anything that's growing this direction. And then we'll put it there in the little cup. We'll swirl it around and send it off to pathology to have those sample cells there for them to look at in the microscope. So again, pretty easy, straightforward. Usually just takes, 3 to 5 minutes to do this whole thing and be done. All right, so let's go ahead and talk about the cervical cancer screening guidelines, okay? So let's dig in here. I want you to think about the screening guidelines have recently changed. The American College of Obstetricians and Gynecologists, also known as ACOG, and the ones that most providers follow, at least here in the US. They recommend screening all patients with a uterus, regardless of sexual activity, starting at age 21, and then screening every 3 years if the pap is normal, and include HPV co-testing if the pap shows abnormal cells. So I have it all written down here for you. So just listen and look at the screen there. It's there. And then from ages 30 to 65, they have a little bit of difference. Um, they can do the cytology alone every 3 years, just like they've been doing. Or if they would like to, they can do a pap smear combined with HPV testing, also known as co-testing, every 5 years. And the reason behind this is because HPV is the number one cause of cervical cancer right now. And ultimately, that's what this pap smear is looking for. But there's oodle caboodles, dozens of HPV strains, and the low risk ones, so not the ones related to cervical cancer, are often cleared on their own from the patient without any intervention. So while we're here, let's just take a look here at this little box. HPV has some high risk strains. So again, the patient often will clear themselves of the HPV, but if they have HPV 16 and 18, they're going to be at higher risk for related cancers that are related to HPV. And then two other strains is going to be 6 and 11, which often cause genital warts. So again, these are kind of your higher risk strains here. However, the good news is that we do have a vaccine, Gardasil, that we can give to prevent HPV, especially the high risk types is what it targets. And again, it's been named Gardasil, and it's been approved for at the age 45. And we're given that as low as 9 years old sometimes in some cases. And this has dramatically reduced the risk of cervical cancers caused by HPV. So, with that good news in mind, the American Cancer Society, which you'll see at the bottom of the screen here, recently updated its guidelines to reflect the reduced cancer rates. And their guidelines state cervical cancer screenings start at age 25, and age 25 to 65 will have a primary HPV test every 5 years. And if primary HPV testing is not available, screening can be done with a co-test that combines an HPV test with a pap test every 5 years, or a pap test alone every 3. So again, ACOG is going to be the one that we are utilizing the most. American Cancer Society has updated some of their guidelines, and then most people will stop doing PAPs at age 65 who have had normal screenings for the last 10 years. Now, you ask, what if my patients had a total hysterectomy, i.e., removal of the uterus and, more importantly, the cervix? We can stop screening unless the hysterectomy was done as a treatment for cervical cancer or other precancerous conditions. And just a few caveats here. If this patient has been vaccinated against HPV or had any part of the cervix left post hysterectomy, they should still follow the guidelines for routine screenings. And one final thing to consider here is that if a patient has a history of a serious precancerous condition, regardless of their age, we are going to continue the pap test screening for at least 25 years, even if they're over the age of 65. So again, these guidelines will pertain to most patients, but we always want to do these individualized care plans like we talked about at the beginning. And, if they're 72 and they had cervical cancer at 69, they're still getting PAPs. So just, utilizing those outliers and knowing your guidelines, and again, using it as a guideline, as a framework, as an outline, and utilizing individualized patient care is going to be really important. All right, let's go ahead and talk just a little bit about some of the things that you might see on a pap test. So we talked already about who gets a PAP, how to perform a PAP, but we need to know what to do when the results come back on that path report. So we're going to most likely look at the American College of Gynecology and Obstetricians again, and basically that's going to help us to know what practices, what they usually will follow. So there's nothing to memorize on this slide for you. I just wanted to kind of give you the slide to group everything together and show you what you could see on a path report. But again, any abnormal findings are going to be grouped into cytology, and it looks at individual cervical cells, and then also histology, which is looking at the actual tissue as a whole. So for cytology, that's what this slide is talking to. It can come up with multiple things. So the most common one is going to be this ascus, or atypical squamous cells of undetermined significance. So we don't really know what this is. This one is just some sort of cellular disruption around the cervix. It could be something as simple as a tampon all the way up to, some precancerous condition. And then atypical squamous cells, they cannot exclude like a low-grade squamous intraepithelial lesion or a high-grade squamous intraepithelial lesion. Um, and then also you could see adenocarcinoma in situ. You might see that on a path report. So depending on the cytology, you're going to manage these patients in lots of different ways. So let's go ahead and look at that here. So one of the things that I would know is this slide right here, and I've kind of wrapped it up for you with a neat little puzzle. Um, since the most common finding is ascus, we know that this can be caused by HPV. It could be caused by intercourse, the tampon, just anything that causes that cellular disruption, like I just mentioned. So really, these cells didn't look uniform up under the microscope. So the next thing that you would do if you have ascus come back is to have the HPV test run. So remember, we talked about co-testing. If that HPV test or human papillomavirus test is positive, then we're going to rule out for a colposcopy. Now, you guys actually picked on the first question we had today, you all picked the correct answer. So that is a deeper look at the cervical cells and a biopsy to confirm what exactly is going on there at the pathology. So you see, this patient's going to get referred out to GYN if they have any of these conditions, and they can actually take a little bit better look. They can light up the area, they can magnify it, and they can also take a little biopsy if needed, and then treat these patients accordingly. If the patient has ascus and the HPV is negative, then usually we'll just kind of repeat that PAP on the normal timeline. Or if the patient's kind of nervous or the provider's kind of nervous, then they can decide that they want to do this for peace of mind and bring them in sooner for the PAP, maybe 6 months, 12 months. Because remember, we kind of talked about how it can be a few years in between PAPs if the HPV is negative. So again, this is just going to be an informed decision between you and your patient. Again, back to what I talked about, individualized care and shared decision making. And then also, I've got listed here for y'all high grade squamous intraepithelial lesions, atypical glandular cells, or that adenocarcinoma in situ. These are all going to be prompt referrals to gynecology. And again, if they have that low grade intraepithelial lesion, then these patients also will get the HPV testing done, find out what's going on. And as long as it's negative, we could probably repeat it in 6 to 12 months. So again, but if that HPV is positive for either one of these two things, these are more ambiguous, then we're going to go ahead and refer them out for colposcopy. And again, that's going to most likely be performed by the GYN, and they'll be taking a look a little bit more deeper at those cervical cells and utilizing that magnifying tool so that they can initiate prompt treatment for that patient. All right, let's go ahead and talk about the histology, which we talked about the cytology pretty good. So histology, the changes to the cells are going to be graded CIN, and that stands for cervical intraepithelial neoplasia 1 through 3. And then also there's adenocarcinoma in situ. And usually these first little grades here, you can repeat the PAPs in 6 to 12 months if the HPV testing is negative. But if we see kind of getting to a 2 or 3, it needs to be referred out for a colposcopy and possible biopsy of the tissue. So again, depending on what you see on your path report. And again, the thing that I want you to remember before stressing about all of this is primary care, if that's where you're at, we're going to consult the guidelines and we're going to make those appropriate referrals. So don't get too hung up in what we've just kind of gone through. Know the guideline, know when to screen, know what to do, when to refer, and you're going to be okay. Because we don't want to miss these precancerous cells. And of course, we always want to offer this prevention via vaccination of Gardasil, like we just talked about, starting ages 9 to 45. And we're going to be recommending that to patients as well. If they get it younger, they only have to have 2 shots. If they get it after, I think it's 15, then they have to have 3. So it's good to go ahead and get these patients before they become sexually active. That would be ideal. All right, let's go ahead and look at a practice question for you guys. And I've got the Slido up for you. So let's take a look here. All right, so y'all did a great job with the PAP testing, right? I'll pull it back up for you for just a second. Y'all got it. You're going to refer to gynecology for colposcopy. And you guys knew exactly because when we have ascus, which with HPV, like we just talked about, this patient is going to go on and get that colposcopy done. So let's go ahead and introduce our next topic, which we're going to talk about mammogram screening guidelines. And let's kick it off with a practice question. So Miss Angel is 24 years old, and she asks when she should start getting mammograms. After reviewing her family health history, the nurse practitioner notes that her mother was diagnosed with breast cancer at age 42. Which will be the most appropriate response by the nurse practitioner? So let's take a look at our options here. This is not select all that apply like that other one earlier. And we could start mammogram screening at age 32 as it's 10 years before the mother's cancer diagnosis. The American College of Obstetricians and Gynecologists recommends starting mammogram screening is at age 40. I will order a breast ultrasound for you today, or I'll order a mammogram for you today. So, what do you guys think would be the best option? Again, thinking about shared decision making, thinking about pertinent to the patient and their family history and their concerns. What would you suggest we offer to Miss Angel today? So I'll give you just a minute to look over that and think about that. And again, offering to the patient what you would like to be offered to her. All right, so I'll give you just a second, and then we'll go ahead and get right into the meat and potatoes again of our screening guidelines. All right, so here's that question again. If you're just now joining us, you can still join on Slido. The QR code's there for you. I've got it up here for you. So take just a minute, think about the question again. And you guys got it. Y'all did a great job. We could start mammogram screening at age 32 as it is 10 years before the mom's cancer diagnosis. So absolutely right there. It is true. ACOG does recommend starting mammograms at age 40, but for this patient, we're going to start about 10 years prior to offer her a mammogram due to her family history. So let's talk a little bit about the breast cancer screening guidelines for this patient. So there are several sets of guidelines for this that have been created and published by a lot of reliable sources. And since today we're really focused on the United States Preventative Task Force, we're going to start there. And then, of course, ACOG and just take a look at everything. So the first thing is that these guidelines changed a few months ago to closer match with ACOG guidelines. And we'll go ahead and look starting at age 40, mammograms every 2 years. And then, of course, at 75 plus, we can consider discontinuing mammograms. Right here, you can see age, this is ACOG, 40 to 45, you'll offer the mammogram to patients, and then 45 to 75, the mammogram every 1 to 2 years, depending on risks. And we don't want to wait until after the age of 50. We want to get them in their 40s starting on mammograms. And then again, 75 plus, discontinue the mammograms. And then taking a look here at the American Cancer Society and the National Comprehensive Cancer Network, you can see pretty similar. Around age 40 is where they're starting. These ones are probably not followed as closely, but they're still there. And you have to think about risk versus benefits. National Comprehensive Cancer Network used to offer them pretty young there, but again, they've kind of changed that in recent months to start at 40. And but most people, I would say, are doing over here the ACOG and the USPSTF. And again, I think in general, 40 is a pretty good consensus rule of thumb, starting those mammograms. And then 75, if they want to get it and they feel like they're going to live a long time because they're, a healthy 75-year-old, that again, that's a shared decision making with you and your patient. So again, you can think about, life expectancy less than 10 years. That's when you can consider discontinuing those mammograms on these other guidelines here. All right, let's go ahead and take a look here. A practice question for you. Mr. Hart is 55 years old. He's due for his colon cancer screening. He's on a 3-year screening schedule due to his last colonoscopy confirming a diagnosis of Crohn's disease. He states how much he hates the prep prior to the procedure and wants to know if he can just do a DNA stool test instead. Which response by the nurse practitioner is most appropriate? So I want you to think about here. We'll go over to Slido and we'll look at this. DNA stool testing is not appropriate for you due to a history of Crohn's. You do not need another colonoscopy right now and can wait till next year. You're a good candidate for the DNA stool test, or this is not appropriate, but we could do stool cultures instead. So, what are you guys thinking? You guys are really on it today and doing a great job. But I want you to think about what is going on with Mr. Hart. He's on a 3-year screening schedule. So again, 3, 5, and 10 years are pretty common times. Some patients do have to repeat every year for a couple years if they find something. But 3 years is pretty standard for something like Crohn's. And that's right. Due to the history of Crohn's disease, he is not going to be a good candidate for that, is he? So you guys got it. Absolutely. He needs to go ahead and do that colonoscopy, unfortunately. All right, so let's talk about colon cancer screening and those guidelines. So, why is this guideline here? We've talked about the first cause of death from cancer-related deaths in U.S. is lung cancer. Second cause of death in U.S. from cancer is colon cancer. So, recently, they have actually lowered the screening from 50 to 45. So, due to that fact. So basically, these guidelines are going to reflect the importance of screening. And there are 2 pathways to screen for colon cancer. Still, the gold standard, if you're talking to your patients, if they want to be 100% and they have some sort of strong family or personal history, the colonoscopy is still considered the gold standard because they are actually taking a look within the colon and they're able to utilize that as their screening tool. But again, think about just our question. It's invasive. It requires this horrible bowel prep, requires this patient to have a driver because they're going to be under anesthesia. It's a gold standard, but it's a rougher one. And after initial colonoscopy, the gastroenterologist is going to be the one to determine when the patient should return for a rescreen based upon their findings. So popular ones that I've seen, like I said, are the 3, 5, and 10 years. And then on the flip side of that are those fecal sample tests. These are really on the rise. They are an at-home screening tool. They can be used for these lower risk individuals who've never had polyps on a previous colonoscopy, or have no family or personal history of colon cancer. So again, talking to them about their family and personal history is going to be really critical when you are offering them these home kits. Now, there's several home kits on the market today. One of the most common ones is Cologuard, you guys might have heard of. And essentially, what this test is doing is it is detecting blood or DNA in the stool via a little mail-in sample, and it collects the patient's stool sample at home. So again, a little bit more private, a little bit more comfortable, and if the patient's a candidate for that, a lot of times they are agreeable. These patients will be repeating this test about every 3 years on average, but if a sample reflects a positive reading for blood in the stool, which is what, again, that's what that Cologuard kit is going to be looking for, these patients should be referred out promptly for a GI consult and further testing, i.e., a colonoscopy, most likely. So, again, right here, early detection is key. We want to catch colon cancer early and quickly, and so we don't want to miss that. So again, these patients need to be getting their screenings for that, as it is, again, the second most deadly form of cancer in the U.S. All right, so let's take a look at this one here. Miss Jones, she's 73 years old. She has a FRAX score of 10% with hip fracture at 4% over the next 10 years. Her T score is negative 2.8. The nurse practitioner decides to prescribe Fosamax weekly. What statement made by the patient indicates a need for further teaching? Now, I'm going to go ahead and I'm going to pull this up for you and let you all vote on what this patient needs. So, I will begin a daily walking regimen to prevent further bone loss. I will try to include more calcium and vitamin D in my diet. I'll plan to take my medication at bedtime to reduce my risk of nausea, or I will, let's see, oh, y'all changed it on me. I plan to take my medication, okay, to reduce and then I'll also plan to take my medication on an empty stomach with a full glass of water. So, what are you guys thinking that this patient needs to have teaching wise? So, we know that this patient, things like walking regimens, calcium and vitamin D is going to be helpful. So if you're doing test taking strategies, we can already know that those two are probably going to be correct. And then now we're talking about these two are kind of very similar here, an empty stomach or taking the medication at bedtime. So if you guys know how these biphosphonates are taken, you guys know that absolutely right. Planning to take the medication at bedtime is not going to be correct, but rather this patient needs to take it on a full stomach with a glass of water. So, or sorry, on an empty stomach with a full glass of water. So absolutely great job. So this patient here needs to take it in the morning and sit up for a little while after she takes it on an empty stomach. All right, so let's just get in here. Let's just talk a little bit about osteoporosis. It's going to be one of our final mentions today. So, the bone density screening guidelines. Remember, bone density screening detects osteoporosis and osteopenia. Remember, osteopenia is that stage of decreased bone density before actual osteoporosis. And just as a reminder, our bones are constantly remodeling themselves. So as you can see here in my picture, the osteoblasts, or the cells that build new bones, are not working nearly as hard as they should be, while the osteoclasts, or the cells that break down those old bones, are overactive and leading to that Swiss cheese appearance within the bone. So you can see here, this patient is starting to develop some osteoporosis. So currently, dual energy X-ray absorptiometry. Now, that's a mouthful, so I like to say the word DEXA scan. These are used to screen postmenopausal women ages 65 and older for bone density. And younger women should be screened using a formal clinical tool to determine eligibility for DEXA scan. So most women are going to be screened every other year, and a DEXA scan is going to give you a assigned fracture risk assessment tool, or FRAX score that I have listed here for you. Okay, and ideally, normal is going to be a normal risk of fracture is less than 10% in 10 years, right? We don't want these patients to break a bone if they happen to fall or, have some sort of compression injury going on. So currently, recommended guidelines suggest treating patients with a FRAX 10-year risk score of 3% or greater of hip fracture or 20% or greater risk of major osteoporotic fracture. So, another measurement that they're going to give you on this, in addition to a FRAX score, is a T score. And the T score is essentially representing bone mineral density compared to a young, healthy adult. So, a T score of less than -1 is going to represent a normal healthy bone, whereas -1 to -2.4 is osteopenia. And then these are going to be mainly managed conservatively. And then if this patient has a -2.5 or greater, they're going to have osteoporosis as their diagnosis. And remember, both of these patients, whether they have osteopenia or osteoporosis, we're still going to encourage weight-bearing exercise, vitamin D and calcium supplementation. However, if they have osteoporosis, we are going to offer them actual medications like the bisphosphonates or, these other medications like Prolia, something like that. So we are attempting to remineralize that bone. So remember here, we want to get those osteoblasts working a little bit better. And first line treatment, of course, is going to be the biphosphonates. So i.e. Fosamax, something in that drug class. And if a patient is unable to tolerate those, because remember we talked about in the last question, they have to sit up straight, they have to take it on an empty stomach, they're going to take it once a week, then we can consider those IV meds, injectables, and most of the time these patients may end up in rheumatology offices because they have a more severe case of osteoporosis. Of course, we're screening these women ages 65 and older with a DEXA scan. If they have a low BMI, they're at higher risk. And then also if they're Caucasian, then they have a higher risk for osteoporosis as well. But again, you can utilize screening tools for these patients and see if we need to start screening them earlier. Like, for example, maybe they've had some fractures, or maybe they've been on like long-term estrogen therapy, something like that. You may consider talking with your patient about getting a DEXA scan earlier. All right, so let's go back to our question here. You guys absolutely did a great job on that one, and talked a little bit about when they need to take their medication. So you know that one there. All right, so these were just a few of the guidelines. There are over 80 guidelines listed with A and B recommendations on, everything from, like we talked about, mammograms, osteoporosis, colon cancer screening, lung cancer screening. And you guys have really increased your scores, so that's really good because, several of y'all were kind of down in here when you started today. So again, you're not going to absorb all of this content in a 1 hour lecture, but one thing that we can offer you is, if you want to go back and look through, just like we've talked about before, you can sign up for SurePass, you can sign up for mentoring, you can do a live review. We go over all this again in the live review. So lots of different things that you can look at. You can look on the USPSTF website for yourself and see what you can garner from there as well. So I'm going to give you just a minute to ask any Q&A today. I'm going to put this information back up for you guys. We've already went over it today and talked a little bit about it. But we're here for you. We want you to reach out. If you have specific questions, nursepractitioner@archerreview.com. And if you're joining via Zoom, you will get that contact hour today. So we're super excited to give you that, just like we talked about this morning. If you missed the contact hour today, today, that's not a problem. Just go to our website right here, and we will be happy to give you access for next time so you don't have to worry about it. And I'm going to go ahead, I'm going to open up the chats here, you guys, and just take a look here and see what I've got. Let's see here. All right. Okay. I see that now. This isn't coming up as a select all that apply. You can only pick one answer. I'm sorry about that. I didn't realize that. So thank you for letting me know that, Larissa. I will fix that for next week. All right. So I'm going to give y'all just a minute here. And I have a couple other things that I'm going to poll y'all on here. What content you would like to see in future free live webinars. So I know that you guys are doing a lot of information today. We can come back around and do some more of this. I know that the billing and coding has been a particular area of interest. We got that on the schedule for next month, so check back on that. I know that we recently had that EKG lecture. So we have lots and lots of exciting things coming up at Archer. In fact, professional issues is coming up here just in a week or two. I'm going to give that. So we'll be talking about the professional information with you guys. And I know Morgan does a really great musculoskeletal, so I'll pass that along to her. So give me just a minute. Hepatitis, yes, always tricky, always a hot topic, especially if you're like preparing for boards. So we can definitely do that. That goes with that GI lecture. It's probably still up on Facebook. If you haven't seen that one lately, you can go back and probably watch it, or you can watch it in on demand. We break that one down pretty well for you as well. So I'll give you just a minute. I see a couple people still putting in their answers. Okay, anemia, my big three lecture. I'll do that again coming up soon. Yes, thank y'all. I do enjoy that one because and that one is hyperlipidemia, hypertension, and diabetes. And we actually talk a lot about the guidelines. If you guys don't know, I love to do a guideline lecture if y'all haven't caught on to that yet. So again, I appreciate this because we'll take this and we'll try to put it on the calendar for upcoming webinars for you guys so that you all get the most bang for your buck and you all can get your contact hours in, and it will be things that you're interested in. So I want to go ahead and come back over here. If you all have joined us on TikTok or Instagram today, it's been really great to see you guys. I've been super excited to try this out, and I think it went well. And we'll plan to be back next week with y'all together. And I think there's some more things coming up over the next couple of days. So check back. If you haven't registered via Zoom, you have to do that to get that contact hour. So make sure that you go to our website, you register to join us via Zoom. But hey, if you're here on any other platform, we're still happy to have you and so glad that you can join us. So that's all I have for today. And we're going to go ahead and call it for now. If there's any other questions, I've still got it here open in the chat and the Q&A. So if you need to ask anything, I'm hanging around and appreciate all of y'all joining us today. I hope this has been beneficial for you. And I have so enjoyed presenting this information today. So, all right. Well, I'm going to end it there. And if there's anything that we can do for y'all, let us know. And we'll see you all again soon.